Hello and welcome. Welcome to the session. We are talking today a little bit about tricuspid disease, and you already see on this slide two patients, and I want you to work with us together in the next 1 hour to discuss what kind of options we do have for such patients. My name is Jörg Hausser. I'm coming from Munich, and I'm sharing the session together with Didier JJ from France. And I think we will have a very excited and a very interactive session with you. You're going to see different parts. You see already that we have a nice model up here. And we have a distinguished panel, as you see, which will help us in the next hour to do this session. We're starting with Miriam Körber, Miriam Wild, Sam Dawkins, Hendrik Träger, and Federico De Marco. And I think we're going to start right now.
Yeah. So once again, it's very important that we keep it lively. So these are really sessions dedicated to you. So it's a kind of small room. The setup is fine. So if you have any kind of thing in mind you would like to share, we have these microphones and we can get to you very easily. So don't be shy.
And I think while you already see these slides, I think we're going to present now the two patients so that you get a little bit of background for these two patients, which we will discuss in the next hour. Federico.
Okay, so you've seen the patients on the large screens. Now we will go a little bit more into the clinical characteristics of these specific patients, and we're going to see the options that we do have for these two patients, which look quite similar, but in fact they have some differences. The first one is an 84-year-old male, atrial fibrillation, like more than 90% of all our tricuspid patients, a dual-chamber pacemaker. So we have a pacemaker lead crossing the tricuspid valve. He has COPD. He underwent a right heart catheterization showing a systolic pulmonary artery pressure of 50 and a mean pulmonary artery pressure of 34 millimeters of mercury. The V-wave was prominent with 20 millimeters of mercury at its peak. The patient has some reduced GFR. He has a low ejection fraction. The RV is dilated and the TAPSE is a little bit below the normal value. So the Euroscore, the surgical risk for this patient is 10%. The mortality as measured by STS is 8.7, and the TEER score, which we should use to evaluate our tricuspid patients for surgery, is 6, which gives a predicted mortality of 22%. His symptoms are significant. New York class 3. He has right heart symptoms with peripheral edema, loss of appetite, fatigue. He had already had 2 hospitalizations for heart failure, and his NT-proBNP is quite elevated, above 10,000. You see the medications are very adequate with a medium dose of diuretics. Forxiga is in the recipe. And this is his significant and relevant imaging. You see an important degree of tricuspid regurgitation with a vena contracta width of 19.5, regurgitant volume of 95. We see 2 scallops in the posterior leaflet. We see also the pacemaker lead, which has some interaction with the septal leaflet, and you see the color jet of this patient. Let's do a quick raise of hand. Who thinks that this patient needs a transcatheter intervention? Raise your hands.
Percutaneous procedure, yeah.
Yeah.
Consensus.
Who of you thinks that this is a good case for tricuspid TEER?
We would go for TEER?
Okay.
Okay.
Good portion of the audience. Let's see quickly the other patient. Again, 88 years old. He's very symptomatic, ascites, New York heart class 3, symptoms of right-sided heart failure. Again, ejection fraction is low, 30%, like the other one. AFib again, and the same problem with the lead crossing the tricuspid valve. He had a pacemaker implanted back in 2017. He has also some degree of cardiorenal syndrome and cardiohepatic syndrome. And again, if we evaluate his mortality with the TEER score, we see the exact same value, 22%. He underwent right heart cath. He has a lower mean pulmonary artery pressure, a wedge of 16, V-wave very similar, 22 millimeters of mercury, some degree of post-capillary pulmonary hypertension, and the meds look in line with the other patient with some average diuretic dose. And again, this is the relevant imaging for this patient. So 3 cusps in the tricuspid valve. We see a lead which is somehow interacting with the posterior leaflet. But if we look at the coaptation gap, this patient is much larger than the one we had before. We had 4 millimeters in the first patient. We have 15 millimeters between the posterior and the septal leaflet in this patient, and 12 millimeters between the anterior and the septal. Again, raise your hands if you think that these patients needs to be treated with a transcatheter intervention. And who thinks this is a good case for TEER?
TEER? Interesting. So maybe we can stop, just pause, just to get your feeling about why you think that this patient could be a good candidate for TEER, and what would be your strategy, technically wise. It's interesting.
Sure. So it depends on the gap between the septal and anterior leaflet. The real gap is not where the pacemaker is. The real gap, where are you going to grasp the leaflet? So what I would do MPR to see the grasp location, to see the gap, the real gap. Because sometimes the 2D on the 4-chamber view or on the mid-esophageal views won't give you the real gap, because sometimes it gives you orthogonal, not grasping location. So I would reconfirm the grasping location gap.
Okay. And do you consider it to be a challenge for TEER, or?
It is challenging.
Yeah, it is a challenging TEER.
It's like the orange or red zone.
Orange and red. Okay, thank you very much.
Well, we are already here in discussing the patient in the red zone. So, who of you has always some connections or some experience with a tricuspid valve replacement? Because this is apparently what the majority of you thought about. Who had some
TTVR?
TTVR? A few? Oh, quite a few actually. Okay. Well, it's going to be very interesting, and I think we're going to start a little bit with the data what we do have for such therapies. And I think we start with Miriam, and it would be great if you tell us a little bit about the data what we do have from real world with respect to the treatment of tricuspid regurgitation and the experiences. Miriam.
Thank you very much for having me. So, as it was already suggested by the hand raise poll, I will come back to the patient. So mine was the first case, the patient with massive to torrential TR, high surgical risk, all these comorbidities, very clinically advanced, but anatomically suitable for a TEER procedure. But with all these comorbidities, do we feel comfortable performing a TEER procedure? So that's what we did in this case. We implanted 3 PASCAL ACE implants in the anteroseptal position, and afterwards the TR was reduced to mild to moderate. Feeling not secure putting an extra device in the posteroseptal position due to the lead, it was kept in this way. And TR was reduced without elevation of the gradient, and immediately the V-wave dropped to 10 millimeters of mercury as a hint for a successful procedure. At discharge, the result remained sustained. The patient had an uneventful clinical course, no adverse events, and at 6 months clinical follow-up, he was asymptomatic. He had not experienced any adverse events or rehospitalization. So, this was a very successful case with a good clinical follow-up, but notably this patient would not have been included in the randomized controlled trials that we have on tricuspid TEER. So what data do we have on patients like this, especially in this context for the PASCAL platform? And it's my pleasure to share with you this very current data that has just been released today in the morning of the TriClass study, which is the post-market single-arm prospective study investigating the safety and effectiveness of the PASCAL system in severe TR patients, which was conducted at 18 European sites, including 300 patients that were not only at high surgical risk, but also highly symptomatic. And we see on the right side the clinical cause concerning all-cause mortality and heart failure hospitalization with a low event rate. TR could be reduced to moderate or less in almost 90% of these patients with a sustained results up to the 1-year follow-up. And notably, over 80% of the patients had been previously hospitalized for heart failure in the year prior to the intervention, and this could markedly and significantly be reduced in the 1 year following the procedure. Complementary data is available from real-world registry data for the PACE registry, which was an investigator-initiated trial, multi-center, retro and prospective, including consecutive patients undergoing the procedure with the system at 16 European heart valve centers without applying any inclusion or exclusion criteria, and therefore marking a true all-comers patient population. And all echocardiographic imaging was subjected to a centralized analysis. And looking at the clinical and echocardiographic characteristics, we find that our patient exactly matches these parameters with all the comorbidities, the presence of a lead, the chronic kidney disease, previous heart failure hospitalization, the high symptomatic state, and dilated RV with a reduced function and a higher degree of TR. In the PACE registry, notably including patients from very experienced sites, we could also find a significant reduction of TR severity at discharge in 87%, which was also sustained at 83% at 1 year. And as we know that the success of the procedure and the success of the TR reduction is of imminent importance in the clinical outcome of these patients, data from this registry helps us to better understand who are the patients at risk for a non-optimal result, because due to the high patient number, we could have a very detailed multivariable analysis, and we could find that the baseline TR, as well as anatomic characteristics such as the tenting height, coaptation gap, but also the presence of a CIED lead might be predictive of a less likelihood of successful TR reduction. And one important aspect that is also added by this registry data is the importance of experience on clinical outcomes. And notably, the median number of patients per site per year was 21. So there was a very high level of experience and high patient numbers in all participating sites. And so we divided the patients according to lower and higher center experience with a cutoff of 21. And we found that the intra-procedural success rate, according to the newly implemented TEER criteria, was significantly higher in higher experienced centers, which translated into a higher clinical success rate at 30 days as well as at 1 year for these patients treated at a higher experienced center, and also a lower rate of single leaflet device attachments. So in conclusion, tricuspid TEER with the system is a safe and effective treatment option for severe TR, also in these high-risk patients that are clinically as advanced as our case example, and the procedure leads to an efficient as well as sustained TR reduction and clinical improvement, but center experience and the possible centralization of these procedures with the whole platform of options we have for the tricuspid valve is linked to a higher early and also longer-term success rate. Thank you very much.
Thank you very much. So these are very impressive data, real-world data, but quite reassuring in the ability that we have to treat tricuspid regurgitation with these TEER devices. So let me ask you, who has experience with the PASCAL system in the tricuspid valve? Okay. So maybe we can, for those who have experience, we can share a bit of that experience. So I'm coming to you. So what is the first type of device that you use in terms of, is it the ACE or do you use the P10 for the tricuspid? What is the rationale for that?
It's the ACE because I think it's quite easy to handle, and if you have a lot of chordae, it's easier to use the device for that purpose also. maybe it's not based on scientific, but for us, it's the first device. If we just think that we could be fine with one device, we could also sometimes don't use the ACE, but the alternative.
So ACE for you first, because of the mainly about the ability to navigate through the dense chordae that we find in the tricuspid subapparatus. It makes sense, and I think that potentially the ability to grab a little bit, to capture a little bit of the more leaflets within the system.
Is somebody using the P10 as the primary device?
P10 is the PASCAL with the spacer.
And the 10 millimeter width, so a little bit
Yeah.
grasp more leaflets. Apparently not, but this is also reflected in the two studies where almost 98% are treated with the PASCAL ACE system. That's very interesting.
So I'm always intrigued by the combination of a tricuspid regurgitation and the lead. And we have a kind of patient to treat tomorrow, not exactly the same patient, but there is an ICD lead, and it's a kind of a challenge. So I'm pretty much interested in trying to capture the experience of those who have already treated a patient TEER with a lead, as it was in the case. Does anyone have experience with a TEER and a lead? TEER? No one? You? So would you, I'm going to throw it to you. So the thing is, do you aim at trying to isolate the lead in one of the commissures, or do you try to navigate around the lead and try to capture the leaflet regardless of the position of the lead?
It depends on where the TR is coming from. So if it's in the posteroceptal and I want to capture the enteroseptal, it's not going to be an issue. But sometimes you have to navigate. You have to take catheters like Agilis, try to push it down and take it away from your grasping zone. But in the case you showed, the first one, it was in the posteroceptal, away from the majority of the jet. So I usually don't worry about it.
Thank you very much.
Another important aspect is always the cords, and you can get entangled in cords. Who has some negative experience with getting entangled in the cords? Because the PASCAL system has the option perhaps to work around with this elongation. Are there somebody who has some experience with the cords? Didier?
I had, yeah. And it's about experience. But it's true that we don't really see what's going on below the leaflets.
Yeah.
And I'm pretty sure that maybe some you have experience like that. We're going to see that potentially in the simulator, but it's quite dense below the leaflets. And if we don't pay attention to the way we open up a little bit the arms and we navigate, avoiding to be too deep, sometimes we can get entangled. And it's true that with the elongation feature of the PASCAL, it's something that has changed a lot our practice here.
Great. I think we still have a little bit of time. But something you want to add on the system. What is the most striking aspect of the PASCAL system which you like?
So I think there are a few features that are very helpful in handling complex anatomy. Obviously, has already been mentioned, the elongation. I think the ability, the fact that the device isn't keyed, so you can change the orientation of the guide and the steerable in any direction, means that you can address any steering issue. So the most common steering problem you have in the tricuspid position is septal hugging, and that's readily corrected with the guide in the standard position, just putting on guide flex. But if you're reverse septal hugging, if you need to gain height, if you need to lose height, you can do all of that, and it's very iterative. So you can experiment with the position of the guide port and do whatever you need to do to correct the steering. And we all operate on a cohort of patients with really challenging anatomy. They might have had a couple of previous stenotomies. They may have massive atrial dilatation. They may have osteoporosis, for example. And all of those things can make the steering really challenging. And so having the ability to correct any steering issue in any plane is a big feature for me.
Another feature I think is maybe worth mentioning is that the clasping is more atraumatic. So in cases where we think that we might need to have multiple grasping attempts, we feel more comfortable using the system.
Well, another feature of the PASCAL is the independent grasping, so that you really can do subsequent grasping. How often are you using this, Federico?
So for tricuspid cases, especially when you start having some coaptation gap, I think that's a very useful feature. I would say I use it definitely the majority of my time, close to 90%.
Okay.
I would say it's quite exceptional for me in the tricuspid to use simultaneous grasping.
And which leaflet do you start with? The septal one, trying to bring it to the lateral, to the anterior, the posterior, or do you try with the longer leaflets, start with the longer leaflets and trying to pull them?
I usually start with the lateral and try to bring it.
And that's a very, very important statement, just to respect a little bit the frailty of the septal leaflet. That is most of the time shorter and sometimes even tethered as compared to the opposite one.
The tethering is much more.
And I have one, because we can see that the experience for TEER with the PASCAL device is not that big, so it would be interesting to go through a couple of technical steps for those who are not familiar with. And the very first thing that we could tell our friend is, what is the orientation of the thing that you use for the system? Sam, for the tricuspid, we know for a mitral, for the tricuspid, what would it be?
So in the tricuspid position, you know, it looks the same. The only difference really is that you put the port at 12 o'clock rather than 4 or 5 o'clock. The fin is the same. So the fin is at 1 or 2 o'clock in the home position. But it's worth, you know, once you've steered down towards the valve, I find it helpful just to experiment with all the movements and make sure the movements are pure. And make sure that the septal lateral movement is pure, the AP movement is pure. And time, we've talked about this in some of the mitral sessions, time spent above the valve is worth it because you're not going to interact with anything. You can really fine-tune the two things which should be thought of separately, the trajectory on the one hand and also the position. And to set all of that carefully above the valve saves you a lot of trouble under the valve.
Same experience for you, Hendrik?
Yeah, absolutely. I think you should always make sure that whatever you're trying to correct, when positioning the device, you only have a one-dimensional movement. If you have a secondary movement, you should correct the starting position.
And these are very, very important aspects of the procedure for those who are going to start. And I'm sure once it is available, you're going to love it. You're going to use the device. So we've heard that we should start with the flush port at 12. It's very important to try to understand how the device is going to move, is going to react above the anatomy, because you don't want, and we've said that, you don't want to get entangled within the chordae. So you just need to understand how it's going to react, the septolateral movement, if it's going to be a pure movement before you dive through the valve. We said PASCAL ACE could be the preferred option to start with, and I think it's a very wise advice. And I do believe that with the elongation feature of the device, it may save our time and spare a little bit of stress during the procedure if we inadvertently we end up too deep and entangle.
Isabel, do you have any tips and tricks from the imaging perspective? Where do you start? Do you start in the deep esophageal view, or how often are you using the transgastric view?
I mean, in my experience, the biggest tip is actually get really good at the transgastric view, because sometimes transesophageal in the transgastric space can be really hard, and you do have some kind of shadowing there. And of course, then it's useful to get into a deep transesophageal, but sometimes even those are not so perfect. And we can do really good imaging sometimes from a transgastric space, and it's sometimes even possible to do a lot of the clocking and also stuff like that. Besides the trajectory, that should be done transesophageal, but you can do a lot of in the transgastric, but the transgastric needs to be perfect, because if it's not perfectly aligned, then your position's wrong. And this is, I think, my best tip. You should really be very good at a transgastric view. You can even do an NPR from that if you don't have any possibilities in the transesophageal space then. So if you have a good transgastric and if you're really practicing that one, I think that would be my best tip.
And for the leaflet grasping, what kind of view do you prefer?
Yeah, actually...
And is it different for the lateral, anterior and posterior leaflets and the septal leaflets?
Yeah, that's a very good point. It's very personal experience, but for the lateral, you usually see it very nicely in the transgastric, actually. And then sometimes the septal is a little shorter, as we've already said, and the septal is sometimes also a little more tricky to grasp because it's sometimes tethered or short. And then we like, if you have a good transesophageal, we like to check the septal also in the transesophageal views, because sometimes you can see it there quite nicely. But overall, grasping can only be performed in a transgastric view because sometimes you can see very nicely, even after closing, how the leaflets come in on both sides. But if you do have a good transesophageal, of course you can check there as well, especially the septal. But avoid to go up and down all the time because might be some cases of traumatic injuries of the esophagus.
Excellent.
Very important aspect of the imaging. Let's talk a little bit more about patient indication. We saw these two cases with the differences in the gap size. What do you think? What is your appropriate gap size for an edge-to-edge repair? And when do you think perhaps we should not consider such a therapy? And I'm going to ask. Let's ask for up to 4 millimeters. Is this acceptable? Who would treat such a patient? 4 millimeters?
Yeah.
Not so many. I thought I would have expected that everybody's raising his hand.
It would be interesting if we could bring back both pictures, both images of the patients.
Can we get the first images?
The very first image when our friends entered the room?
Yeah, this one.
The forum, yeah. And now you get two sets of patients, slightly different challenges. And the very first challenge that I have, not being an imager, is to try to understand the number of leaflets that I have. And Becky is coming. So before we get to you, Becky, there is okay. It's all about understanding the anatomy of the patient. So I think that seeing that echo image is the first step, just to understand about the challenges of the patient.
So may I ask a question to the panel? I mean, do you think it's acceptable to use volume modification to change the gap size?
Well, that's only
playing with volumes.
That's a very important point. So the question for you guys is pre-ab, volume change before the procedure. How important is it? Intra-procedural as well. Federico?
So I think it's a very important strategy, especially before we had TTVR, before EVOQUE was approved, we tried to push the limits of prehab, really to try to shrink those coaptation gap and to make treatable with TEER patients which ultimately maybe are not, because once the patient gets his normal volume after TEER, we will have lots of tensions on those leaflets, and we might pay the price of an aggressive prehabilitation. Now that we have TTVR, I think things have changed a bit, but still it's an important point to diurese the patient before the procedure.
If I might add there, I think it's a valuable strategy to make a patient eligible for a TEER procedure. But I think 2 points are important. Don't trust the result you see at the end, because if you have aggressively put the patient on a hypovolemic regimen, you have to treat the anatomy as well and not only trust the jet that you see at the end, and do not reduce the diuretics at discharge of the patient, but remain on a stable diuretic dosage for a couple of months before re-evaluating.
But there was another question I thought about intra-procedural aspects of volume shifting. Any comments?
I was just going to add something to the previous point, and I've certainly come to that. I think it's worth saying that the philosophy of fluid management for TEER is different to TTVR. So for TEER, particularly if there's a big gap, prehab makes a big difference, and we have a fairly minimalist approach in our healthcare system because we can't bring patients in for days and days before the procedure. What I tend to do pragmatically is double the diuretics for 3 days before, and that makes a big difference to reduce the coaptation gap and help you with your procedure. And then for TEER patients, afterwards, I tend to put them back to their usual dose, but definitely don't reduce it until you see them in clinic a month or two later. For TTVR, we need stability. So what you do not want to do is have a big change in their fluid balance between the sizing CT and the procedure. So we want to get them euvolemic for the CT scan. Ideally, it's much easier to manage if you keep an eye on their weight, because then you can be precise about it. And then later on, when they come in for the procedure, you don't want it to be much different because you don't want to have different sizing. I quite often do volume management during the procedure for mitral and and pressure as well. I don't tend to do it for tricuspid. I don't know whether I'm an outlier on that one, but yeah, mitral, yes. I don't so much for tricuspid.
So for intraprocedural volume shift, it has been proposed to perform this table tilt maneuver, making a venous pooling in the under extremities. And it could have been shown that the coaptation gap can be reduced in many patients by around 25%, also making it more likely to achieve a good result.
Has somebody some experience with changing the ventilation? There's Becky, please. There you are.
Yeah, so we use both PEEP and Valsalva. So this is a mechanical forced Valsalva, which will indeed reduce the preload, just as PEEP would. And we can go up to even 20 of PEEP and for short periods of time. And it significantly reduces the gap, but it might also change the anatomy a little bit. So you just have to be continuously imaging.
Careful.
Yes.
Absolutely.
And how long can you keep the patient with such a high level of PEEP, in your experience? How long?
I mean, it's minutes that you can do. They're watching continuously, and I mean, we've had that high PEEP for like 3-4 minutes, sometimes even.
Probably even longer.
And even longer is okay. And they're just watching. The other thing we'll do, because of the respiratory variability, is just reduce the
tidal volume.
The tidal volume significantly, even down to 200, 250.
Very, very important advices.
So, but I think the other message for the tricuspid valve replacement preparation, I think, is very, very important. That you need to do your screening, including echo and also the CT, at a time when the patient is in the euvolemic state. He's really optimized for the diagnostics, not for the procedure. And then you want to keep this status until you treat the patient with a valve replacement. Very important aspect.
Let me ask you one thing, guys. We see both echoes of the patients. So, given your experience, what you would do at your center, who believes candidate case 1 is a perfect candidate for TEER? Raise your hand. Okay. And more case 2. Case 2 is more appropriate for TEER. So it seems that we have more or less the same feeling, that case 2 is a little bit more complex. But to me, one thing that I am always struggling to understand, who is an interventional cardiologist here? Please raise your hand. Okay. So this is only a question for an interventional cardiologist, so I'm going to come to you. My question is, have a close look at the transgastric view of case 1. How many leaflets do you see? You get...
I don't know.
I don't know. The answer is I don't know. How many?
5.
5. And you? Any clue?
5.
5. So then I'm going to turn. And so let's go back to the
ask
imager.
No.
Before the expert. We have experts as well.
Becky,
Isabel, how many leaflets do we see here? Because it's so difficult.
I would say 4, but let's see what Becky says.
It's not.
No, I agree. There's 4, but there's the usual semi-cleft a little bit in the septal leaflet. So the septal leaflet, the anterior portion of the septal leaflet frequently has direct chordal attachments to the septum, and those are hard to get, but you're going to have to get it if you're going to affect the result. And then you see the posterior portion of the septal is relatively free, has regular chordae to papillary muscles. So I think 4, but a really difficult anterior septal portion.
So it's quite a difficult case, I would say, and I was positively impressed by the final result that you get.
Absolutely.
And I have to say that in my experience, I try to keep the focus on the area of interest where I think I'm going to capture the leaflet, and to make sure that I have a gap that is acceptable and that I can see the leaflets. Because the more you see, the better you're going to be at capturing these leaflets.
Another aspect is now for the right patient, you see the RV function. How do we assess best the RV function, especially if we're thinking that such a patient might be better off perhaps with a valve replacement? Is this an acceptable RV function, and how do we assess this? Isabel, that's a question for you, I guess.
Yeah, it's a tricky question, and I mean, we do not have hard evidence to answer that question yet. I think one of the most important points is that we should not look only on the longitudinal function, but it's very important to look at the radial function. In my very personal opinion, factors like 3D ejection fraction, but also factors like RV free wall strain, stuff like that should be important in the future. And also RVPA coupling is probably a factor that tells us something about the ventricle. But to be fairly honest, besides the fact that we should not only look on the longitudinal function, we don't have hard evidence, or not, it's scarce at least, the evidence on that. So we will need to find out, I think, over the next years.
So how many of you are using TAPSE for the assessment of the right ventricular function?
TAPSE?
TAPSE? And fractional area change as a two-dimensional assessment? Also many people? What about three-dimensional techniques? 3D echo for the ejection fraction? Not so many anymore. What about cardiac MRI? Are you using this on a regular basis?
Sorry.
I'm biased because I do cardiac MRI anyway in my practice. So.
Okay.
And do you find it more precise, MRI, the way you assess the RV function?
Thanks. MRI is always sold as a gold standard for volumetrics of the ventricles, which is, I should defend our bastion, but it is still remaining subjective and operator dependent, and you need to be very precise and careful how you contour your ventricle to get good and reliable and repeatable results. So yeah, but I would vote for MRI on
MRI.
I do
would
both.
be your first choice, yeah.
Wonderful. Okay, I think let's...
Up, just up. Yes.
Hi. I have a question for Becky and for the imager, because we know that one of the risks is to be trapped in the apparatus cord, okay? And one of the points of the glide score that is something that a majority of guys now are using is the apparatus chordal density. It's something really... because normally it's something very difficult to obtain and difficult to analyze and to put the marker on that point. So how we can improve on that area?
So you have to throw it. Becky! I'm coming to you.
Isabel says also, so those transgastric views are our favorite to look at chordal density because the chordae are perpendicular to the ultrasound beam, and that allows us to see them better. And they'll be better than the mid-esophageal and deep esophageal views. I think you can see some chordal on CT, but the temporal spatial resolution is poor. And so what we're really looking for is just spaces between the chords, but there are like millions of chords on the tricuspid side. And most of the time, even though we say, oh, we see a little gap there, it's just once you get in the procedure, you're just going to try and find a way to get to the leaflet, to the base of the leaflets and the leaflets to go in. So I think we use it, but remember there are many, many other parameters that the glide score used just 5, and there's so many other parameters that we look at for device success, like leaflet to annulus ratio and things like that. So things that are not captured by glide, but by other studies.
Oh, yeah.
Thank you. Freud.
Yes, Alison. Yes.
Yeah.
You're gonna get it.
No, just before I have to leave, sorry to... so a couple of things. Great cases, by the way. It would be easier to see the picture on the top left-hand screen, but one thing we haven't mentioned is that there was a fairly significant septal fold which was making the septum look bifid.
Can we see the picture?
And actually, if you do start with your edge-to-edge intervention in the anteroseptal area, or even the central area, anything anterior to that, when you close the gap, this has happened to us twice, you open that fold, and then your gap between the posterior leaflet to that septal area increases, so that makes it very difficult. So I think that case on the first case, transgastric on FAS, was actually a very complicated valve, because not only that is the case, and it's a 4, possibly 5 scallop, but the septal fold was a danger area, and just anterior to that was also a pacing wire, so that made it complicated. In answer to the question about right ventricular function, it depends on your question, because any number of echo or CT or MRI measures can measure RV function. That's not what we're asking. The question is how bad is the RV in a volume-loaded RV, and that is what we do not know when you've got torrential tricuspid regurgitation. So it doesn't matter if you measure it on MRI or 3D echo. All the numbers are off. If you've got a volume load, nobody knows how to fix that. And the final thing is, I would agree with Becky and the thing about the cords. It's a pain in the neck, because often you can't find them until you're in them, and then you wish that you'd seen them beforehand. So it's very difficult.
Thank you. Okay.
Okay. So let's move to the next part of the session. So any question coming from the what about coronary sinus spacing? Okay, coronary sinus spacing, meaning that you what is the there is a question coming from the audience about the you have a tricuspid regurgitation, you have a lead across the tricuspid valve, and then the proposal is to remove that lead, to put a coronary sinus lead, and then go for the procedure. Is it something that you've done? Have you ever done that? Or is it realistic? What do you think, Federico?
I think, lead extraction carries a risk. So there are lots of risk factors considering, how much time the lead is there, what is the interaction with the actual heart. So I think that's written somewhere, but I have the feeling that no one really does it to try to, remove leads to reduce TR.
It's something that comes up often in conferences, but not so often in real life. In exactly. Pacing specialists are generally quite reticent to remove pacing leads. And the problem is, obviously, the risk of that procedure, which is substantially higher than tricuspid TEER, but also the risk of damaging the leaflet as you take the pacing lead out. So unless it's a brand new pacing lead, generally we leave it where it is.
But now we're talking about tricuspid valve replacement. Do we need to do it differently?
So tricuspid valve replacement, you can largely ignore the pacing leads actually, because for replacement, you jail the pacing lead outside the valve. How many EP colleagues are here?
Who has experience with EP? Not only interventional cardiology, sometimes it's...
Would you remove the lead before, excuse me, before such a procedure? What are your concerns?
I don't think that we remove the leads, yes. If you want to do this, I should use from leadless pacemaker or something like that.
Leadless.
Many EP people I talked to about, they are really scared when we are pushing the leads with an EVOQUE valve to the side, and they're always fearing the complications of lead and device infections.
Another thing is
very risky.
It's difficult to be sure that lead removal is going to be effective in reducing TR, because sometimes when you remove the lead, you still have TR because you still have some effect on the leaflet.
So the consequence is at the end, as probably many of us do, we usually keep the lead in place also for tricuspid valve replacement, correct?
Yeah, exactly.
But I think even more than lead extraction, an emerging topic is the valve sparing techniques of CAD lead implantation. So for example, the CS lead might be a valid option in a patient that has already pre-existing tricuspid regurgitation to not further deteriorate valve function, for example, or also after an EVOQUE implantation valve replacement strategy, if you have the need for a CAD lead, it can be evaluated to place a CS lead. And at our center, we have a lot of experience placing these leads, and it is to be noted that you can only use the bipolar CS leads, and maybe we need some evolution in the field.
I think we're going to move on.
There is one final.
Oh, sorry.
While you are setting up everything,
but please, perhaps in the meantime, everybody's getting set up.
I just want to make a mention. Like when you implant the lead, often we forget about the tricuspid. As long as you check immediately after, in a couple of months, you are able to see if you put too much loop, and that's a time where you can move the lead up in If you leave it a year or so till the next echo, then you're going to find that it's already irreversible, the changes on the tricuspid. But if you act quick enough, you can guide the loop and move it easier.
We're also going one step further than that. We're doing currently a study to do the lead implantation using echo at the time of implantation to try to reduce the TR. It's an ongoing randomized trial, but hopefully we're going to show that.
So just a word from the U.S. side. We had to work with our EP colleagues to generate a consensus statement as kind of mandated by the FDA because they were pretty upset at us for jailing the leads. And the consensus statement says that, and it's true with the data, that a lead within 2 years is very easy to remove, extremely easy to remove. And rather than jailing with the risk of endocarditis, which will basically kill the patient, and lead dysfunction, which we believe may occur in about 10% of cases, then the thought in the U.S. is that we collaborate with our EP colleagues to remove the leads. Within 7 years, you can remove the lead using advanced techniques, so typically lasers, but that requires obviously a site that has extreme experience. And beyond that, they don't really want to touch it.
This is a very important summary of the recommendations for the management of patients with tricuspid disease and with the planned valve replacement. And I think we're would like to show you now how such a procedure is being performed, what are the main steps. And I'm very happy that the 4 of you are going to show us now how we're going to do this in practice.
Great, thanks very much.
We started with the recorded case. Sorry, then we start with the recorded case. Sorry.
We start with a very bit of a recorded case, and then we're going to see live in the simulator how it's performed.
So this is the patient which we already have seen with a large gap and the lead. That's me.
I'm going to insert this catheter system. Now you see by fluoroscopy that the catheter system has arrived in the transition of the inferior caval vein to the right atrium. We're going to pull back now this blue sheath, which will allow us that we're going to bend the catheter tip, and we're going to do this with this light gray knob that, as you can see by fluoroscopy, that we move slowly forward and bending the system down into the right ventricle. Now, if you look first by the fluoroscopy, this is where we're positioned now in the right ventricle. And if you look at the MPR, the multiplanar reformation by echocardiography, you see in the green box the anterior posterior direction, in the red box the septolateral direction, and in the blue left lower box the transgastric view. And the lines are superimposed on the current position of the delivery system. You can appreciate that we try to be perpendicular to the valvular plane. And as a next step, now we're going to generate the capsule gap, which is a marker for us how deep we are with the anchors already in the right ventricle. For this, I'm going to work on this white knob. And if you look by fluoroscopy, you see this circular marker at the nose cone, which is now moving to the left slowly. And this now generates this capsule gap. Now, if you look at the echo, you see that the blue line is positioned at the level of this capsule gap, which is approximately 10 to 12 millimeters below the valvular plane. We will now expose the anchors to 45 degrees so that they're flaring outside in the next step. And this will allow us then to re-evaluate our depth. So I'm going to work on this white knob, and by fluoroscopy you can appreciate how these anchors are now at 45 degrees. By echo, in this 45 degree of the anchors, they are a few millimeters below the valvular plane. We are at a position where we think that we now can go a little bit further with the retraction of the first capsule, which will then result that the anchors will come out to 90 degrees. This is what we're going to do now by fluoroscopy. You see I'm going to pull back a little bit this outer capsule. Now we are at a 90 degrees position.
Okay, so this was the first part. And now I think we're going to see this live, how it's really performed in a model, which will give us some additional insights.
Great. Thanks very much, Jörg. So we have a very impressive synthetic beating heart model here set up by the Edwards team. And this is based on a patient. It's a 3D print of a CT scan. And so here we have the EVOQUE transcatheter tricuspid valve replacement system. I'll just talk you through some of the controls, and then we'll have a look at the imaging. So, yeah, you can see my hands now. So on the right-hand side, we have 3 controls. So these are the controls for the planes of movement. So the first one is primary bend, so that's flexing AP. The second one is secondary bend, which is flexing septal lateral. And the third one is depth. This control here controls the nose cone and the tapered tip, and we have a safari wire in the ventricle here. For release, we have the ventricular deployment and the atrial deployment. And I'll show you the planes of movement in just a second. But Isabel, why don't you tell us about the imaging setup, and then I can go through the planes of movement.
Yeah, thanks, Sam. I mean, we've seen a little bit in the recorded case already, but I really want to introduce a little more this MPR home view, as we call it. MPR is short for multiplanar reconstruction, and it's a little similar to CT. But how do we get to this view? You have to try really hard to get a really good 2D image, and usually that's a deep transesophageal view. Then you have no shadowing and on the tricuspid valve. And if you have a good view on that, you just take a 3D volume, and then off this 3D volume, with MPR, you get 3 orthogonal planes, and you can administer these planes in your area of interest. So let me quickly introduce you to my screen. What we can see here, as I've already said, is the home view. In the home view, you can see in the blue box, so the upper right panel, basically a view that corresponds to the transgastric TOE view. We can see, and this is very important, that the aorta should be placed around 5 o'clock. So the anteroseptal commissure is at between 5 and 6 o'clock. Then the anterior leaflet is around this area. I hope you can see my pointer there in the blue box, so ranging from 9 until 6 o'clock. Then you have the posterior portion of the valve in this area here, and the septal leaflet, so the septal portion of the valve around here, so between 12 and let's say 6 o'clock. And then you can see that there is a yellow line dissecting here from posterior on the upper side to anterior on the lower side. And then this view corresponds to the yellow box because it's the yellow line. And we can see here in the yellow box, so lower left panel, on the right-hand side, we can see the anterior portion of the valve. And on the left-hand side, the posterior portion of the valve. And this goes also similar for the white line. The white line dissects the valve from the septum here on the right-hand side up to the lateral portion of the valve. And then you can see in the corresponding white box the septal portion of the valve on the upper side and the lateral portion of the valve on the lower side. And this allows us very time efficiently and without maneuvering the probe all the time inside the esophagus of the patient to effectively see trajectory, position, and also then later on during the spin to check all of the anchors with just one spin, we will see it later on, to check for leaflet engagement. So this is the beauty of this procedure, that actually we can stay, I mean, here, hopefully we can stay in this plane, because otherwise it will be hard. But even in real life, you can stay here during the whole procedure if you set it up nicely.
Isabel, this is great, and I think it's really clear to everybody. But we have a cheating view. Who can explain us?
We also have no fluoroscopy, so we're allowed.
Yeah,
so the cheating view, the boroscope view, is set up to mimic the short axis transgastric.
So we have then on the right upper side the septal leaflet.
Correct.
So we have the anteroseptal commissure at 4 p.m. more or less, and the anterior leaflet in the lower part and the posterior leaflet in the left upper, correct?
Exactly.
Wonderful.
Nice. So we have, this is going to be a fairly swift deployment here. So to tell you where we've got to so far, so we're at capsule gap, okay? And I'm just going to demonstrate the planes of movement for you. So first one to show you anterior position. So look at the bottom left screen, position, not trajectory. What I'm going to do is advance, and if you watch the left-hand bottom screen, you'll see as I advance, I move towards the aorta. And as I retract, I come back. So that's generally very predictable, very responsive. The second part of AP movement is the trajectory. Our trajectory is pretty good, but just to demonstrate it for you, if I put more primary flex on, do you see how I'm changing my trajectory to favor more posterior? So I'm now going to undo that and leave it pointing more or less perpendicularly AP. The second plane of movement is septal lateral. So if you look at the bottom right screen, if we're going to change position, all I do is unlock, and if I torque septal, if I torque clockwise, I will swing septal like that. And then the other way goes lateral. So I'll leave that in the middle. Mostly, if you're going to have to make a correction, it's because there's a little bit of septal hugging. It's not so bad here, but I'll just show you the second plane of movement. So watch the bottom right-hand view. As I put secondary bend on, you can see that we center up and correct our septal lateral trajectory. So we're going to do the timeout now. So we have capsule gap, which is something that we can all see. My part of the timeout is to say that the port is at about 2 o'clock, which is where it usually is at this stage of the procedure. I've got about 1 of primary, 1 of secondary, and no additional depth. What are your thoughts, Isabel?
Wonderful, thank you, Sam. So what's important, we have to see and have to look also for the capsule gap here in the echo, and you can see it quite nicely. I put my blue line on it, and this is very important to look also for depth. And the capsule gap should definitely be way below the leaflet closure at systole, so in the area, let's say, between systolic closure and the diastolic opening. But this is definitely deep enough here, so this looks perfectly fine. And then what's also really important, actually, this valve in the simulator looks a little similar to the recorded case, because it also has 3 leaflets. And what's now very important to be totally sure where your commissures are. This is not too hard in this model. So as I've already said, anterior septal commissure 5, 6 o'clock, then AP commissure 9 o'clock, I'd say, and then the PS commissure at around 1 o'clock. Why is this important? Because later on, if we expose the anchors, it might be that one of the anchors ends up in one of the commissures, and then it can't be clearly engaged, which is fine as long as the anchors both anchors next to it are definitely engaged. So this is very important now that we can see where the commissures are, and then everyone on the table is clear about that.
Great. So timeout is complete. I think we're all happy to carry on.
Yep.
Roma, are you happy? Very good. So I'm now going to start to expose the anchors. So this is the white knob turning away from me, and you can see the anchors starting to appear on the echo and on the boroscope. Now we're gonna jump through some steps here. So we'll come to this point and just make sure we're happy with the height. And if we are, I'll just go straight to 90 degrees if that's all right.
Looks good, yeah.
You want any more depth there, or are you happy as we are?
Minimal, but it's actually, I think it's fine. You can see quite nicely that the septal leaflet, which we sometimes worry most about, is quite nicely engaging already, falling onto the valve, moving freely here.
So I'm continuing to about, probably getting to 90 degrees there, I think. And when you do, each movement you do, it's good to backpedal a tiny bit just to stop it continuing to expand.
Tiny bit posterior.
So position is a little posterior, so I'm going to advance a couple of clicks. So that's centered up quite nicely, I think.
Perfect. Yeah.
And are you happy with anterior there? Are we Pinning it a bit? Probably not. Probably all right, isn't it?
Wait, let me check. I mean, you can see it nicely. You can see it better if I rotated here this yellow line onto one of the anchors, then we could see it a little better. It looks okay, I think, actually. You can see I'm looking at the yellow box lower left panel. You can see quite nicely that the leaflet is going inside the valve, moving freely, even like, yeah, pushes.
Well, shall I flip the anchors then, and then we can do a spin?
I think definitely yes, yeah.
Okay, so flipping the anchors is exactly as it sounds. I'm going to get the anchors to point up. So I'm just continuing the release. And I'm just watching. And we generally stop a couple of stages as we do this. So I'm going a little quicker than usual just to make the most of the time. So anchors are getting there. So I might pause there and then let you do a spin.
Okay, now I've talked a bit about it already. The spin is where we check for anchor engagement. Anchors engaged mean, as you can now see, in my opinion, quite nicely in the yellow box. You can see that the anterior leaflet here falls nicely and moves freely inside the valve. If it's pinned, that's what we don't like. It means that you push the leaflet away and that it's not above the anchors and inside the valve. So we now check for each of the 9 anchors with one spin. We will check for leaflet engagement. Now it's very important that we start, and everyone is clear where we have to look at now. We start at the anteroseptal commissure at 6 o'clock. So what I do now, I will move the yellow line in a clockwise manner. And then we all have to look in the yellow box on the right-hand side. So now we can see the anchor at 6 o'clock, and corresponding view here, we can see very nicely that exactly at this anchor, the leaflet is falling very nicely and moving inside the valve or above the anchor. So this is definitely engaged. And this we check for every anchor just by rotating it. As I've said, very time efficiently, you can see it again. Always you have to look in the yellow box right-hand side. You can see it as well here. Leaflet goes above the anchor, moves freely inside the valve. This we go on and check. Here we can see it also moving freely, nicely engaged. Now I'm around 11 o'clock, again, very nicely visible. Then 12 o'clock, now we have to be sure or aware that there is the commissure. So it might be the case that it's not engaged here, but it actually is engaged. Still looking at the yellow box, right-hand side. Here it's a little shadowy, but I think we can still see that the leaflet moves very freely above the valve, so this looks also fine. Now I'm at 2 o'clock, same picture here, definitely engaged. Now I am at 3 o'clock, also looks very good here. Then I will be around 4 or 5 o'clock. Also here, leaflet is engaged, and then we are very happy with our spin.
So I'm not going to do anything until we're back at home view, because otherwise you can get very confused, but we're getting to the end of our time. So I'm going to continue if you're happy for me to do so. So we're continuing the ventricular expansion and watching in all the imaging planes just to make sure nothing is changing and make sure we're happy with our position and trajectory. And so I'm going to finish ventricular expansion if you're happy with that.
Perfect, yes.
So I'm coming to the end now. There are some fluoroscopic landmarks for that, which you can normally see, and we'll see in Jorg's case. So coming to the end of ventricular expansion there. And so I'm just going to bring back the tapered tip as we've done that. Okay, so happy to continue?
Yes, very much so.
So the height is nice,
yeah,
isn't it? I think
that's what I wanted to say. It looks really good. Yeah, the height. We've come up, of course, but that's what we wanted to do. You can see the hinge point. I'm looking at the yellow box again. Hinge point of the leaflet quite nicely. And just below the hinge point, as it should be, you can see the anchor tip. Looks very good here.
So I'm going to continue with atrial release if you're happy with that.
Which is now the blue knob?
Yes. So white knob is at end of travel. I'm now moving to the blue knob. And you'll see we just do this. We tend to do this in stages. I will do it in one stage this time. We tend to stop halfway. So this is all looking nice. I don't see any trajectory problems. Nope. I don't see any height problems.
Yep.
So I'm just going to continue with this to end of travel.
Yep.
And the valve is already working?
Yes.
Nice.
And we are released.
Yes, you are. Yeah.
Perfect. I think we're going to move on because we're just a few minutes left. Going back to the case, you see the same steps in the patient. Can we have the slides back in the video?
Now, if you're going to start the spin, we're going to still focus our view in the green image. You see anchor by anchor how we're going to slowly rotate the planes, and that the leaflets are in this 360 degrees still nicely that they're still nicely above the device. This is important so that we confirm our position of the device in relation to the leaflets. We are now in the posteroseptal commissure. We look at this in the green box coming to the septal part. And now we go back to here's the septal leaflet lying on the device. Here also, and now we are back in our so-called home view, where the green line is again through the anteroseptal commissure. With this confirmation, we can now continue with the expansion of the device. What we're going to do is with the white knob that we're going to flip slowly the anchors so that they're pointing to the right atrium. And you're going to see this also in the fluoroscopy. If I'm going to continue here very slowly, that they are now pointing back. Now we have performed small adjustments to the position of the valve. Now, if you look at the echo, you're going to see in this home view that in the green box, but also in the red box, the leaflets are nicely falling onto the device, so that we're going to continue now with the further expansion with the white knob. You can see this also by fluoroscopy, that we're going to slowly expand the valve a little bit bigger, and I'm going to stop here before we then go to the full expansion of the ventricular part. As you can see by echo and also by fluoroscopy, we performed a slight modification of our position to really confirm that first that the leaflets are lying up on the anchors, but also that our tips of the anchors are already close to the hinge points, so that we have a stable position in the annulus when we do the later release. With this position, we are very happy, and I would now continue with the release of the ventricular part. By fluoroscopy, you can appreciate how the valve is getting bigger, and now we're going to go back with this outer capsule to this marker where we are currently. And we will then do another evaluation, because in the next step, I will work on the blue knob, which will expand the atrial part of the valve. When you look at the echo images, you see that we have positioned now the valve with the anchors right at the hinge points. We confirmed that at least most of the anchors are underneath the leaflets. Just where the commissures are, we have one or two anchors where we could not confirm that the leaflets are lying upon them. This is not of a major concern, because all the other anchors which are next to the ones at question have a good leaflet capture. So that's why we're going to now expose the atrial part. And if you look at the fluoroscopy again, you see that the valve is getting now bigger, and we're going to stop here. With the last step of the implantation, we're going to do this final release, which I do with this blue knob again. And now you will see that the atrial part is fully expanding. And then the valve is going to be set free here. And now it's free. And now we should have a good and stable position, which we're going to evaluate. We have this very nice stable position of the valve in the tricuspid annulus. If we're adding some color, you can see why the catheter system is still in the right ventricle, that we have already a nice reduction of the tricuspid regurgitation. And then the next step, we will now retract the system to the atrial part. And now we can also re-evaluate by echo our valve. You see that we have almost no, well, there is no regurgitation. There's a tiny color jet when the valve is closing. You can, yes, there is no paravalvular leak. The pacemaker lead, which you can see by fluoroscopy, is a little bit under tension, but so far everything looks perfect and stable. The inflow gradient, which you can see, is the 1 millimeter of mercury over the entire diastole.
Excellent. So congratulations. So I'm always amazed by how comfortable and stable is the patient through the procedure, and even as an operator is so relaxed. So after this fantastic demonstration and the recorded case, maybe it would be nice to summarize the latest data that we have before we wrap up the session. We could discuss for hours, but I think it's very important to understand how it can impact our patients.
Okay, so before we are running out of time, I'll give just a short overview of the most recent data that we have. And of course, you're all aware that we just recently had the publication of the TRISCEND 2 data, the first randomized trial that evaluated tricuspid valve replacement. And if I get the slide, I can show you the most recent data in a second.
And a little bit lower.
You're searching.
That's me. Okay, so
here we go.
This is what you've already been seeing now. The device has been introduced to you. So this is the design of the TRISCEND 2 trial. Again, that was the first randomized trial to analyze the effect and the efficacy and safety of replacement compared to a continuation of medical therapy. And patients were randomized in a 2-to-1 fashion. And this is basically the most important evaluation. First of all, of course, is it safe? And yes, in general, it's safe. However, we see if you split the analysis of the data from the first year into early events within the first 30 days and into late events after the first month, and you see there is some slight price to pay for the implantation. It's not as dangerous, so to speak, as surgery, where we usually see in way younger and less sick patients, mortality of about 8 to 10% in registry data. We see now here an early mortality of 3% in the TTVR arm with no mortality in the control arm. However, this is basically later cancelled out in the following months, where there is a slight trend for mortality in the control patient. And this is most likely all driven by some severe bleeding events in the first month, most likely caused by the procedure and some rather aggressive anticoagulation regimen. One was say, I think we all agree in the routine, we only use OAC and usually DOAC in these patients, and for the study, aspirin was added as well. So this might be one of the things we have to consider when interpreting these data. However, one important thing that hasn't been mentioned so far is that there is a slight there's some need for pacemaker implantation in these patients. In naive patients, 1 of 4 patients is actually pacemaker dependent after the procedure or within the first days. So this is something you have to keep in mind. Also, when you plan your procedure, you should always have something on site to pace the patients if they go into AV block right after release of the valve. But again, you have to pay a price, but what you get is seen here, and this is quite impressive. Compared to all the other repair trials that we've seen so far, you have basically complete abolishment of the TR with 95% of patients that have mild or less TR after the procedure and 99% who have less than severe TR. So very impressive data and also sustainable again for the entire year. And this is now the efficacy data in terms of what is the benefit. And this was, again, an analysis that was done in a win ratio of a combined endpoint that was ranked. So basically what the authors did is they of course, decided as mortality is the most important endpoint. So first, the patients were basically paired in virtual duels, and then we decided, or the authors analyzed who won these duels in terms of mortality. And there was a slight benefit, not significant, but a trend for all-cause mortality in the TTVR arm, and all the ties went to the next level, and so on and so on. And if you add up all these duels in the different hierarchies of this ranked composite endpoint, that you end up with 62 to 31% of wins for the TTVR group. So this was a win ratio of 2.0. Highly significant, but again, it was mostly driven not by mortality, not by heart failure hospitalizations, but by quality of life endpoints. And if you have a look at the Kaplan-Meier estimates for all-cause mortality, you see these results, so no significant difference after the first year between both groups. However, there is, of course, a slight numerical trend for maybe a benefit for the TTVR. And if you split it again in a landmark analysis for the first month and then the later months, you again see what I've already shown you in the safety data. There's a slight price to pay, but it might be offset in the coming months. This is also true for the hospitalization data, where there's no significant difference. However, if you're hopeful, like we all are, I guess, you might see that after 8 to 9 months, the groups start to diverge a little bit. So we're all very much, of course, looking forward to seeing the long-term data that will follow in the coming years. And again, most importantly, I think also for our patients, because this is why they come to us, is the improvement of quality of life in all these three metrics that the authors chose to analyze against KCCQ score, NYHA class of at least 1 degree improvement, and 6-minute walk test, all significantly improved in the TTVR arm compared to the control group. So to sum it up, it's impressive data, I guess, in terms of quality of life, but we'll have to see long-term follow-up data if we have also improvement in the hard endpoints of heart failure hospitalization and mortality.
Thank you very much. Okay, guys. So we're coming to the very end. So I think that we all learned together that we now have suitable therapies to treat our tricuspid regurgitation patients. We've seen the benefits of the PASCAL device for these suitable anatomies, as well as the EVOQUE. And it was really nice to see the live simulation. And it was really nice to discuss the potential anatomical challenges, how to pre-op the patients, how to manage the diuretics, the fluid control. We also discussed about the conduction disturbances issues, and these are really relevant issues for our tricuspid regurgitation patients. So I would like, having said that, I would like to thank you all for attending the session. Thank our discussants. You were marvelous, wonderful as usual. Thank Jörg for moderating the session, and thank Edwards for setting up such an educational session. Thank you.